Tēnā koutou katoa and hello everybody. Welcome to the Lentil Intervention Podcast. My name is Ben Adelberg and I'm coming to you from Tamaki Makaurau, Auckland.
And g'day, I'm Emma Strutt and I'm currently coming to you from Gungaloo country in Queensland. Before we dive into our conversation today, I'd just like to acknowledge the traditional custodians of country throughout Australia and their connection to land, sea and community.
The Lentil Intervention is an Australasian educational and advocacy platform dedicated to raising awareness about the current climate and health crisis.
And on this podcast, we invite guests to chat about topics that will inspire you to take action to improve your own health and the health of the planet.
So please subscribe to and share this podcast and visit our website for the full show notes.
Don't forget to buy us a coffee if you'd like to support our work.
Back in November 2021, the health coalition Aotearoa, of which we are a member of, invited our next guest to present on cancer prevention. It's not a happy topic, so to speak, but for our listeners in New Zealand, and in fact Australia or anywhere else you may be, it's an extremely important topic to understand for the reasons we're going to cover. So we're absolutely delighted to have managed to squeeze into an extremely busy schedule.
That's right. So today we're joined by Professor Diana Sarfati. She's a public health physician, cancer epidemiologist, and health services researcher with a ridiculously impressive resume. Diana currently serves as Chief Executive Officer and National Director at the Cancer Control Agency New Zealand. Professor Sarfati also serves on a number of boards and advisory committees, including the International Advisory Committee to Lancet Oncology, the International Agency for Research on Cancer's Pacific Cancer Hub, as well as their International Expert Group on Social Inequalities in Cancer, just to name a few. Professor Sarfati, it's a privilege to be able to have a chat with you today. Thank you so much for joining us.
Oh, look, it's an absolute delight to be here. Thank you for having me.
Di, if we can start our conversation with a little story from you. Personal background. Tell us a little bit about yourself and your whole journey and your interests as well in this whole topic that we're going to cover.
Well, I was born and raised in Wellington, New Zealand. My father was a general practitioner. And so I grew up always wanting to be a doctor and helping people. So I did become a doctor. So I worked clinically for a while, and then I decided that to really make a big difference, looking after the health of populations was the direction that I wanted to go in. And so I became a public health physician. So that's a specialty branch of medicine which focuses on the health of populations. It's quite a broad specialty. It covers everything from, managing things like COVID to thinking about preventing cancer, but also planning health services and a whole variety of other types of roles. I went into academia. So I did a lot of teaching and research, and my research was primarily focused really on looking at inequities in cancer survival. So looking at why some people or some groups of people tend to do better from cancer than others. That was my primary area of interest. But I had a whole lot of other areas as well. And as a public health physician, supporting people to stay healthy is of really substantial interest to me. So I ended up doing a lot of work to shift the national dialogue in relation to cancer and to get stronger leadership in relation to cancer in New Zealand. And so long story short, I was asked to set up a new entity in New Zealand, the Cancer Control Agency. So that was at the end of 2019. And subsequent to that, I've been the chief executive of that organisation, Te Aotearoa, Cancer Control Agency. And it's been a fantastic privilege to be working sort of on the other side of the advocacy. It was sort of inside the whare, I guess, inside the house, as opposed to on the outside. And that's provided me with a whole lot of new and interesting insights, but also given me the opportunity to really make a difference, I hope. And one of the areas that we're particularly interested in is, of course, preventing cancer.
Now, with the Te Aotearoa, apparently I believe there's a special story with the weave in the logo.
Yes.
Tell us a little bit about that.
So when we set up the organisation, we thought really carefully about what our role and function is. And really, our role is to lead in relation to cancer in New Zealand. So we have a national leadership role. We advise government in terms of investing in cancer, but we also have a role in pulling together the cancer sector, which is very broad. It extends across, prevention and primary care, secondary care. There's diagnosis, there's treatment, there's supportive care, there's rehabilitation, there's end-of-life care. There's a whole lot of different elements to that and services and support that people need. So we don't provide those services, but we provide the structure that allows those services to thrive, if you like. We also are very much focused on being equity-led in what we do, and by that we mean focusing on eliminating inequities, and particularly in New Zealand, between Māori on one hand and non-Māori on the other. So there are substantial inequities there. So we're equity-led. We're also we put people in the centre of everything that we do. So we're really concerned about making sure that we are thinking about the people that we're serving when we, when we do our work. So with all that in mind, we work very closely with our Māori colleagues, and in particular an organisation called Heahuru Mōwai, which is the Māori Cancer Leadership Network in New Zealand. And they worked alongside us in terms of setting up the organisation and thinking about how we do business and incorporating Te Ao Māori in the way that we do business and making sure we centralise equity. And they gifted us the name Te Aho Te Kahu, which means the binding weave of the cloak. So if you think about a traditional Māori cloak, at the top part of that, there's a sort of a band which holds the cloak together. So that's the aho. And so metaphorically, our role, if you think about all the strands of the cloak, those are all the people affected by cancer, the services that provide service to them, all the organisations involved in cancer, and our role is to connect, to pull together, to create a metaphorical kahu, a cloak, which envelops people in whānau, families who are impacted by cancer. So that's what our name means, Te Aho Te Kahu.
That's really quite special. So let's talk about cancer in New Zealand then, maybe starting with the very basics. So what are some of the key points our listeners should be aware of in regards to diagnosis each year and some of those common cancers?
Yeah, so cancer's the leading cause of death in New Zealand and in Australia and in many other developed countries. Cancer is really a whole lot of different diseases with certain characteristics in common, but each cancer has a different set of characteristics. The most common cancers are skin cancers, bowel, breast, lung, prostate. The ones that you tend to hear about, those are the most common cancers. Something like 1 in 3 people will be diagnosed with cancer at some point in their life. So it is a common thing. The other thing about cancer is that as our populations grow and age, we are expecting to see more cases of cancer in both countries, in both Australia and New Zealand. And so the burden of cancer is increasing, even at the same time as the individual risk for many cancers is actually coming down a little bit. But because we've got an aging, growing population, the burden of cancer at a population level is still going up. So cancer is a really important thing. The costs and complexity of cancer care is constantly increasing, and it's increasing at a rate that's far outstrips the rest of the health system. So it's very complex. Cancer impacts the entire health system. So it has an impact which is not only personal and impacting people and families in very real ways. And just about everybody's impacted at some point, either directly or in their family or their friends. But also it has a huge cost to society, both directly in terms of healthcare, but also in terms of productivity. And, so really, no matter how you look at it, cancer is a really, really important issue. Hypothetically, a third to a half of all cancer is preventable. And so that's a really important thing to keep in mind. I say hypothetically because that, in order to prevent a third to a half of all cancers, it would assume that everybody in the population was eating a really healthy diet, everybody was exercising regularly, everybody was not smoking, so it's a bit hypothetical in that we will never have a population that behaves perfectly in all ways. And I would not myself for one moment suggest that I behave perfectly in all ways at all times. So, we wouldn't expect that, nor would we even be aiming for that. But that's a sort of a hypothetical best case. We can certainly reduce a lot of cases of cancer. And I just want to be super clear when I say that, that does not imply that anybody who is diagnosed with cancer is in any way responsible for their own illness. They're two very, very different things. And that's for several reasons. Number one is everything that causes cancer occurs in a particular context, the context in which people live. And every decision that we make, consciously or unconsciously, relates to the environment in which we live. So even things that are apparently individual decisions are made in that context. So that's the first thing. The second thing is, even when you've got a cancer that, like lung cancer, which is strongly associated with smoking, even in a smoker, you cannot say definitively that smoking caused that cancer, because sometimes people who've never smoked a cigarette in their life still get lung cancer. So you can never say that somebody caused their own disease. So I want to be super clear that whilst we want to prevent cancers, that is not the same thing as saying that anybody has done anything to cause their own cancer.
Is it possible to determine, in terms of causes of cancer, how much of it is lifestyle related, which you've mentioned some of those components, smoking, physical activity, diet, and so on, versus environmental causes? Especially there's a lot of conversations now around the impacts of climate change and the impact of air quality, the impacts of fossil fuels, and so on. So is it possible to get a sort of a gauge between the two?
There's a slightly tongue-in-cheek statement on that, which is that 100% of cancers are genetic and 100% of cancers are environmental, because actually they don't add up to 100%. You often need a combination. I mean, we get cancer because our cells divide, and everybody's cells divide, and you can end up with problems in your genetic material, which ultimately causes a cell to go malignant. Why that happens might be because you smoke cigarettes, or it might increase the risk, but it also might be because you were exposed to some other carcinogen at some other point. It might be for a whole lot of other reasons. So at a population level, we can kind of say, well, a third to a half are due to those preventable factors, but actually what causes a particular cancer is a really complex interplay of a whole lot of different things. And again, that goes back to the idea that nobody can cause their own cancer or prevent their own cancer, really. All you can do is make as healthy choices as you can, and that will reduce your risk. It doesn't eliminate it. And of course, we all know these sort of stories. I know a 93-year-old woman who smoked a pack a day for her whole life and she's completely fine. That doesn't mean to say that smoking doesn't increase your risk of cancer. It means that she had a whole lot of other unknown, either environmental or genetic factors which protected her. Someone else gets lung cancer having never smoked a cigarette. So all of these factors interplay, and they can't be separated.
On a positive, though, I do just want to ask, I was reading your State of Cancer report before we jumped on the call, and in there it's noted that cancer survival rates over the last 20 years are, increasing. We're doing better there. But interestingly, New Zealand isn't improving as quickly when compared to survival rates in other high-income countries. Why do you think that is?
That's very true. And Australia's at the top of the chart. That Australia's doing particularly well in terms of cancer survival. So, we always compete with Australia, and it's a bit annoying that, Australia's doing so much better, quite apart from the fact that we want cancer survival to be improving as fast at a rate as possible. The reasons for that are complex and not fully understood, and that's partly because it's actually really difficult to compare all the different steps that go into diagnosing and treating a whole array of cancers between two different countries. Just just for simple reasons like the way that data are collected are different. And so you try and do a comparison and you realise that this particular variable means something different in Australia than it does in New Zealand. So there is some complexity at working that out. But what the most likely thing is that there are more barriers to diagnosis in the New Zealand context. So Australia and countries where there are it's really good survival. They often have organisations that do lead in relation to cancer, which we didn't have in New Zealand until recently. But they also tend to have really good facilitated pathways to diagnosis. So, for example, primary care, people working in primary care can access immediately the diagnostic facilities that they need to rule out cancer without having to go through a number of steps. Whereas in New Zealand, often GPs will have to refer to a specialist in order to get a particular test to rule out cancer, and that can take time. There were similar issues in the UK, and they had similar processes, and they're working on exactly the same sorts of issues. So our survival in New Zealand is improving, which is great, but not as quickly. There are other differences as well, and again, it's a little bit difficult to disentangle all of those differences and work out which ones might be responsible for the survival differences.
Now, you've mentioned a little bit on the costs of care. In New Zealand, it's quite high as well. I think we also feature pretty poorly in that compared to a lot of other nations. Is that actually the case? And why? Well, what does it actually encompass? What does it actually mean, the cost of care? Is it just hospitalization? Is it post-treatment? Does it include the impact it has on family if it's the income earner? What does that all mean?
Well, it depends a little bit on what you're looking at, and it can mean all or any of those things. Both Australia and New Zealand have universal health coverage, so patients get their care or can get their care at low or no cost, unlike some other countries. So in some countries, there is very substantial financial burden to patients with cancer, and you'll be aware of stories in the US, for example, where people are left completely bereft and bankrupt because they've had to pay for their cancer treatment. They don't have insurance for whatever reason, and then they have to pay for everything. That's not the case in either Australia or New Zealand. So from that point of view, patients do well. But there are other costs associated with cancer which can be really challenging for people. So, for example, people having to take time off work because they're going through treatment. So in some working environments, their employer covers them for that time and that they actually do okay. In other environments, that's not the case. Or if someone's self-employed, they don't have any fallback, or it might be that people are having to take time off work because they're supporting someone with cancer, and that can be very expensive. There can be a lot of travel associated. If you're having to travel to a big centre for example, radiotherapy, and you're having to go backwards and forwards, there is some financial support for that, certainly in the New Zealand context, but it's generally not enough to cover the full cost. There's often a lot of additional costs that people pay for just additional support that they might need. And again, there is some support for that, but there is a definite financial burden on patients. And when something like this happens, and for many people, they're not in a position to be able to just stop working and to be financially okay. They'll have mortgages to pay, they'll have all sorts of things, and they have to work out how to manage all of that at a time that they're also dealing with this life-threatening condition. So it's incredibly challenging for people.
And this, I suppose, leads into the next question. You've already mentioned that cancer doesn't impact all groups within the population evenly. So diagnosis and outcomes are quite different between Maori and non-Maori populations, Pacific peoples as well. What are some of the statistical differences here?
Yeah, so if we look at the difference between Maori and non-Maori in New Zealand, Maori have much higher incidence of certain cancers. And so by incidence, I mean those are the people who develop cancer in the first place. And The biggest differences are cancers like lung cancer is the biggest, but also things like liver cancer, stomach cancer, cervical cancer. They have higher rates of breast cancer, endometrial cancer, which is cancer of the uterus. So many cancers, Māori have high rates. And those cancers have a few things in common. One is they're often the most preventable cancers, but they're also often the most lethal cancers. So that's really important. So that's another reason why we are really interested in cancer prevention. If you can stop someone developing cancer in the first place, that is the best outcome that we can, that's the best outcome. And particularly those cancers which are very lethal, often preventing it is really the only option if you're wanting to, save lives. Once Māori are diagnosed with a cancer, they also have poorer survival. So even for a given cancer, they have worse survival. So they have, again, it varies by cancer type, but for all cancer sites, bar one, the survival for Māori is worse than for non-Māori. So those two things are cumulative and result in more Māori dying from cancer than non-Māori.
What do you think are driving these disparities? Some of the key issues there?
Yeah, so there's two sets of things. The one set is driving the difference in who develops cancer in the first place. And that's going back to what we were talking about earlier on about the environments that people live in and the psychosocial stresses that people can be under. So if you're living in a situation where you're living in poverty, and we know Māori are more likely to be living in poverty, and that's due to a history of colonisation and being disempowered and being separated from your culture and all of those things. Then we know that in that kind of environment, you're much more likely to smoke. You're much less likely to be able to afford to eat a healthy diet. You're much less likely to be living in an environment that is conducive to good health. You have much higher rates of infections because you are living in more overcrowded conditions, for example. So one example of that is if you have children living in overcrowded housing, they're more likely to be infected with a particular bacterium called H. pylori, Helicobacter pylori. And Helicobacter pylori causes stomach cancer. So, but not until 30, 40, 50 years later. So it means that if you have Māori and Pacific children living in overcrowded conditions, they're more likely to develop stomach cancer several decades later. So it casts a really long, a really long cloud. So that's the cancer incidence bit. And if we could get that right, that would be extraordinarily helpful. And then in terms of the diagnosis and treatment, there are steps all the way along the health system pathway which disadvantages some groups, including Māori. And fundamentally, what that comes down to is our health systems, both in Australia and New Zealand, are set up to work best for people with a European, for want of a better term, a European worldview, a European perspective on what causes ill health, a European perspective on how that should be managed. For that reason, and for those structural reasons, poverty, distance, just those practical things, it's more difficult to get into the health system. People from outside of the European groups feel alienated from the health system. They experience racism, and so they are delayed at each step, or they experience delays at each step. And so there's no one place where Māori do worse than non-Māori. It's at every step, and it's usually just a little bit worse. So if you looked at any given step, you'd think, oh no, there's not much difference. It's just a tiny bit different. But by the time, again, you get that cumulative effect across multiple steps, the impact becomes substantial.
And is this trend consistent globally with other Indigenous communities? So outside of the Australia, New Zealand sort of world, is this seeing the same thing?
Absolutely. You absolutely see both of those things that I talked about, both the incidence and the survival issues. The incidence issue is interesting because when you look internationally, the data on Indigenous people is poor by and large. New Zealand has the best data, just for technical reasons, the way it's collected, the way it's linked, which allows us to do accurate analyses of cancer incidence and survival for the Indigenous population of New Zealand. Australia is getting better, and it has improved. Other countries, the way that they do their analysis is poor and has results in them underestimating the burden of cancer in Indigenous populations. And they are aware of that and working on it, but it does mean that those patterns are sometimes hidden in some other countries, even where it's very clear that the data are wrong.
And do you see the actual lack of diversity within the health workforce itself as a contributing factor here?
Yeah, absolutely. Absolutely. And that in New Zealand, there's been a lot of work towards in the medical schools to ensure that the students that are coming into medical school reflect the communities that they will eventually serve, so that there is an equal proportion of Māori going through med school as there is in the population, ditto Pacific people. And they've now achieved that with Māori. That's still not quite there with Pacific. As you can imagine, some people don't like that system, the sort of preferential entry or kind of different, supposedly different academic standards. But actually, what that's doing is enriching our medical training, enriching our medical trainees, and enriching our health system in all sorts of ways, and focusing on sort of academic accomplishments is a very, very narrow way of considering worthiness, if you like, of being a doctor. And my experience working in a medical school prior to my current role, you see these students coming through, and the richness of experience and the richness of the diversity is a genuinely strengthening thing. And I'm not saying that because it's the right thing to say. You know, it's absolutely true. And unfortunately, most people don't get to see that. They don't get to understand how extraordinary these students are and how much they enrich the experience for all students. So that's medical students, but that's happening across the board. We're a long way away from seeing that throughout our health system, though, because it takes a long time, for medical students to train to be doctors and then to train to be specialists. So, and there are still a lot of barriers in place, but we are making some progress.
And is the med school curriculum acknowledging that as well? So changes within the actual curriculum itself. Not quite sure how to word this correctly. In my head, I know exactly what I want to say, but more acknowledging and incorporating some of the Indigenous ways of, when I say Indigenous, because I'm referring to anywhere in the world, but, in New Zealand, Māori way of perhaps delivering their way of practice. Yeah, I'm asking the question in a mumbled way, but yeah, it's one thing about the environment, talk about that richness, but is the curriculum itself also reflecting that change and teaching perhaps some new things or different things?
It's a really good question. And the answer is yes and no. Yes, there's been a huge amount of effort to incorporate Hauora Māori, Te Ao Māori into medical school curricula. And I think if you compared the New Zealand curricula with international curricula, we would be a long way ahead of most. Having said that, there's a long way to go. So that's the kind of yes and no. And so I suspect that depending on who you would talk to, some people would say, yeah, we're doing incredibly well, and other people would say, we've barely made a start. And I think probably both of those things are true. But there's definitely a lot of effort going into trying to think about how to incorporate Te Ao Māori into thinking about health. And again, that's a very enriching thing to do. As you're probably aware, Māori, in general, Māori views of health are much more holistic and encompass much broader views of total health and well-being, mental, physical, spiritual, health of whānau, families, health of the environment, that all of that is part of health, whereas the kind of a traditional European view of health is, you've got a tumour and it's there and that's what we need to treat and that's it. And so again, there is a potential to really enrich our health system by taking that broader view, because actually all of those things are important for everybody.
And I mean, you've mentioned that we need systemic change to address these inequities and, carve a new way forward. But for the healthcare providers that are already in the system, what can they be doing to, work towards closing that gap quicker than how we're progressing now?
Yeah, and that's another really good question. So there is a lot of activity going on, but again, we've got a long way to go. So there's things like, training health staff in terms of, various terms, cultural safety, cultural competence. That's important, but I think actually looking at the systems and the ways of doing business is even more important. And by that I mean rethinking how we deliver care in a way that makes more sense for Māori community. And you can't do that without sharing power with those communities, because the communities themselves know what the right answers are for them. And the extent to which we resist that and ignore that is the extent to which we don't make progress, because you can't. So what health professionals and health services can be doing now is engaging with Māori communities to find out what they can be doing to serve those communities better.
So I would like to say that we've got a far better understanding now, based on this conversation, on your wonderful explanation of the background and complexities around cancer. It is a scary thing, because 1 in 3 means if it's not you, it's someone close to you that's potentially going to be affected. But you've given what we always like to talk about is the hope and the positive. And, you talk in the hypothetical sense, we can prevent, and that's by way of minimizing, doing the best to minimize the risk, giving ourselves the best chance. So let's look a little bit at some of the health lifestyle factors that we can do our best to control, because this is actually another topic that can be quite complex in itself as well, and probably there'll be some inequities within that. But what we eat, nutrition.
Yeah.
So let's start with that. What in your mind would be a good, because healthy is inverted commas, what's healthy? So what's a good diet to give us the best chance at being healthy?
And your diet is so fascinating, because it's so difficult for research to really identify what parts of diet are actually good and which parts are not. And that's why there's always controversy. You hear this huge amount of controversy. And it's because, of course, everybody eats different things at different times, at different points in their lives. And if you're talking about cancer, you're talking about an outcome that happens 20 or 30 years later, and you don't know whether it was this, your diet when you were a child, or your diet when you're a teenager, or your diet when you're an adult that mattered. And, and everybody, so it's incredibly difficult to disentangle. But bottom line is eating lots of fresh fruit and vegetables, minimizing eating red meat, eating plenty of fiber, eating unprocessed foods. Generally speaking, there would be very little controversy around that kind of advice. And so, it's not rocket science. It's eating unprocessed, fresh fruit food, which has got lots of nutrients in it.
Putting my dietitian hat on now at the moment, though, in terms of nutrition and a lot of the other healthy lifestyle factors, actually, so exercise, alcohol, etc., the message is often focused on individual actions, so what a person can actually do to improve their health outcomes. but focusing a little upstream, those living in more deprived areas, they're more likely to be exposed to unhealthy food. There's typically higher density of takeaway and fast food outlets, typically a high ratio of junk foods in the supermarkets compared to higher SES areas. And, a lot of times behaviour of individuals are strongly influenced by the environment that they find themselves in. So what do you think the solution is here? Do we need more policy interventions?
Yeah, 100% agree. Yeah, 100% agree. So whilst answering the question, what's a healthy diet look like? That's the answer to that question. But how do we address the problem of supporting people to have a healthy diet? That's the real question, and that's an even more challenging question for exactly the reasons that you give. And so that's going back to, earlier on, we're talking about that really it's about the environment in which people live. And so the prevention report that we put out that Ben was talking about earlier on, the focus of the recommendations in that report, or options that are in that report, are all policy, environmental kind of level interventions. For exactly those reasons, that at the moment it's actually really expensive to eat a lot of fresh fruit, for example, fresh vegetables. It's expensive to do that. It's expensive. Junk food is really cheap. Soft drinks are really cheap and they're really accessible. It's really easy to get those things because they are just in your neighbourhood. And those are things that require a more of a policy response. And so there's a range of recommendations in the report, or options in the report, to consider that. And there's a whole lot of things there. There are things around, sort of legislative changes, taxation changes, things like sugar taxes, or making fruit and vegetables cheaper. Providing more information to people that's easier to understand, having some limitations around fast food availability, for example, particularly around schools, requiring schools to provide healthy food to the children in those schools. There's lots of things like that which are far more likely to have an impact than saying to people, you should eat a healthy diet. And I know that because just before I came on here, I ate a chocolate Easter egg because someone gave it to me. And it was in my environment and it was right there, so I ate it. And so I know that that is not part of a healthy diet, but it's in my environment, I ate it. So yeah, it really is about creating those environments that support people to be healthy.
Yeah. And advertising. I'm sure you forgot to mention that, because that's a big
I did forget
component,
to mention that. Absolutely. Yeah, I did. Yeah. And you're absolutely right. So in the department that I worked immediately prior to this, there's a fantastic study which involved putting little cameras on children, which took a photo every minute, and then analysing these photos. And they found, and I can't remember the actual numbers, but some astronomical number of times in a single day that children saw marketing for unhealthy food. It was something like, I'm making up the number, but it was something like 28 times every day they were getting, sweets and, McDonald's and takeaways and whatever, so they're being absolutely bombarded with these messages all the time. And so again, having some limitations on how much marketing there is of that kind of food.
I seem to think, Emma, we covered that with Boyd Swinburne a while ago.
Oh yeah, Boyd would know all about that. Yeah.
It sounds
no,
familiar.
Right.
Yeah. And then throw in the level of the social inequities that we've been talking about, and then that advertising again would change. It's a horrible conversation to be having. Why are we having that kind of conversation? But it's a reality, and I've seen it firsthand, because I do a number of school visits in the sort of high deprivation areas where we take secondhand sports gear and repurpose it and so on. And the conversation of what they eat and their breakfasts and so on, I've seen that firsthand. They have a conversation about what you should eat, and then I'll get invited to a little thing they're having at the marae next door, and I'll go and I'll see then what they're eating. And it's a complete incongruency to what you're teaching and then what you're giving them an hour later. But also part of that is corporate. and I know this is going to go down another path, but it's the schools don't have the funds, like you say, it's expensive. So we can tell them, here's a policy, you need to give them a healthy food, but they don't have funds. And then a corporate comes along and will provide this or provide that. It's free, great. So they're putting food in their stomach, but it's setting them up for perhaps not the best decisions going forward. So there's a big piece around that. And like you say, it's what you do now that you'll feel in 30, 40 years' time.
Yeah. And, and food, I think, is particularly difficult because it's not like you can just, for example, smoking, major cause of cancer. It's the biggest preventable cause of cancer. Lung cancer is one of them, but there's many others. And there's some really innovative legislation coming through in New Zealand, which will, put us towards being smoke-free by 2025. It's basically creating exactly what we're talking about, an environment where smoking becomes difficult. And one of the really innovative things that we're going to be doing is the smoke-free generation. I'm not sure if you're familiar, but basically the age at which you're allowed to purchase tobacco keeps going up every year. So if you are under that age at the beginning, you will never be old enough to buy tobacco. So you just, and it's fantastic. You can't do that with food. Yeah.
Why not?
Tobacco. There's no upside to smoking. Like there's no upside. So you can't say, right, we're gonna.
What about vaping? Where does that sit? Because the amount of vape stores are ballooning.
Yes. I know, and vaping is a real concern. So vaping, it's a lot healthier to vape than to smoke. So if you are addicted to nicotine and you're a heavy smoker, if in order to quit you need to be vaping, that is a better outcome for you. The problem is people who have never smoked are starting to vape. It is definitely less healthy to vape than not to vape. And
the way it's marketed is it's cool. So you're now getting more of the youth into the vaping.
Yeah, absolutely. And it's extraordinary, flavors that are appealing to children and young people and all of that sort of stuff, bringing people into vaping. It is certainly not harm-free. It's not as bad as tobacco, but that doesn't say much. Tobacco is really, really harmful. So, it's really concerning. And I think there is more international attention on that and thinking about how vaping can be made less appealing. So it's still available to those people who want to stop smoking and for whom vaping is helpful, but it's not something, we need to get rid of the cool factor. We don't want it to be the next epidemic that, because with smoking, that's how it started, that was thought to be okay. It was thought to be healthy. It became something that everybody did. And then it was only much later that the health impacts became clear.
Yeah. Well, vaping is still very early days. So unfortunately, there's not a lot of science around it. But, I just feel that vaping is like saying have raw sugar versus white sugar. It's still the same thing.
That's right.
It's a little bit better, but it's the same thing. So, but that's just one thing. So, I mean, we know tobacco is a big factor of a driving force behind the causes of cancer. We've spoken about the need to improve lifestyle measures in general. So the food we eat, that's a complex area, physical activity, but a lot of these sit within the World Health Organization guidelines, which then I feel sometimes there's a disconnect between that and then our own national, whether it's Australia, New Zealand, like our own guidelines. And I feel that with the latest edition for New Zealand, we basically took, like World Health Organization I should have the figures up to have an example, but they'll have a range. They'll have I'll use physical activity for example. They might say do between 2.5 to 5 hours a week, say. But then the New Zealand guidelines would say do 2.5. It's kind of like we take the soft approach every time, whereas that's actually the minimum. And it's the same thing with the eating. And it's the same thing, with the nutrition and everything else. Why that disconnect? Are we just too scared to put people off? But then conversely, shouldn't we be tougher and say, look, the stats are in, you need to raise the bar and aim for that? Why are we taking a soft approach from a global perspective here?
I don't know if I can answer that specific question, but I think maybe going back to our earlier discussions, again, it's thinking about how can we as a country make physical activity the easy choice and the fun choice. And for example, when I was at school, which was, a while back, we did PE, and I used to hate PE because I was a really slow runner and I couldn't catch a ball to save myself. And that was pretty much all PE was. You were either playing ball sports or you were running, or you might be doing high jump. And I wasn't good at any of those. So I assumed that I was, bad at sport and bad at everything. So therefore didn't do any exercise for, 20 years after I left school, basically. And I don't know what it's like now. I hope that they are much more diverse in their approach to physical activity. There's so many different things. Now I do CrossFit 5 or 6 times a week. I have been doing that for about 7 or 8 years. I'm completely addicted. I was quite good at it until I got so old that all my bits started falling off. Not quite, but, falling apart, shoulder, knee. But, there is something for everybody out there, but I think that we don't do very well. We're into the competitive, so if you're good at sport, you do it. But if you're not good at sport, saying to kids, no, just do it anyway. You're useless and everyone will yell at you. But no, you should do it anyway. Is not a very constructive way of getting kids to enjoy what they're doing. So again, it's thinking laterally, thinking about how we can engage people in physical activity, especially kids when they're at school. Like there's so many options. Dance classes, and there can be a competitive sport for those who are into that, but there's there's going for tramps, there's just a whole lot of stuff that they can be doing which are fun and adventures, which means that they identify this as something that they want to do, and then they continue doing it. And then of course it's about creating the environment that allows people to continue doing it, having your safe bike lane so that you can cycle to work without thinking, am I going to be taken out by a bus? Being able to easily, go on, lots of good day treks around, cities and stuff that are safe and, and that you can do those, those sorts of things. It's very similar, creating an environment that encourages and supports people being physically active.
Yeah. And I think the same would be for food as well. It's making it more attractive. And, Emma and I have had this discussion ongoing, and I think, we started off as you have to give up this and you have to do that to give yourself the best chance.
But I never did. Thank you very much.
Okay, maybe I did more so. But
I did not say that.
What we have realized collectively is you need to do it in a way that's more appealing, because you can come across as it's too hard, it's off-putting.
Preachy. Preachy.
Yeah, and it
never works.
It's one or the other. You're either here or you're there.
Yeah.
So it's the same thing with everything. So lifestyle measures, it's the same thing. If you're an addicted smoker, okay, there's something that can be a little bit better. But for the rest, it's all these options. So I think we need to be more cognizant of the environment that we're in. So on that, to start wrapping up, for our listeners, the average person out there listening, okay, I understand, I think I'm healthy, but the person alongside me isn't, and so on. We have this information. How can we be better? I don't want to use the word ambassadors, but how can we better promote or communicate the right information to, say you're in the work office. That's a good example. You're in a work environment. There's people of all sorts of backgrounds, all sorts of, they're in different places, each person. How can you better use the information that you have to encourage others to make better choices, to give them the best chance?
I think at a micro level, like in an office, the principles are exactly the same. So creating an environment which supports people to be healthy. So, for example, suggesting, hey, let's have walking meetings. So, because I get it's so boring sitting inside. So you're doing walking meetings, you're doing your work, you're going for a walk. It doesn't have to be up a steep hill. It can just be wandering up and down the road, but you're moving, and then immediately you're doing something more. You could have a little friendly competition, like how many days in a row can you do 10,000 steps every day? Who's going to beat, or whatever it is, 5,000, whatever, depending on the group that you're with. And, you have a competition and you have it on the whiteboard and who's doing well. You could do those sorts of things that encourage people to move, but not in a judgmental way, not in a you're not doing enough way, because you know what? Sometimes in people's lives, now is not the time where they can take on physical activity or start eating well. They're going through some major issues in their life. They're under really major stress. And right now, they cannot deal with trying to worry about their diet or their exercise, even if those two things might actually help. They just don't have the bandwidth. And so all you can do then is be supportive to them and have those things in place ready for them when they are ready to, take them up. And it's the same with food, deciding, okay, when we have a shared lunch, let's make sure we've got plenty of fruit. We do some nice dips and stuff. We do, it doesn't have to be absurdly healthy that it's really boring, but let's do some, let's be creative about how we can have healthy food rather than just bringing in muffins and cakes and, stuff like that. And don't bring chocolate Easter eggs in, because otherwise the boss will eat one on the way to doing a podcast.
Great start. Professor Diana Sarfati, thank you so much. It's been hugely insightful. In the science world, when we talk about environmental topics, we always talk about the importance of communication science, but it's the same thing in the medical health world as well. And you come across so clearly. It's been fantastic. And for our listeners, share this episode. It's I think the word is empathy. You got to take an empathetic approach to others, but plant the seed and encourage along the way. So, Di, thank you so much for your time. Thank you so much for your passion, everything you do. It's been a real treat for us. Thank you.
Thank you. It's been a pleasure.
Thank you for listening to the Lentil Intervention Podcast. If you found this interesting, make sure you subscribe and share it with your friends.